Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. This episode features content from an educational webinar titled Strategies for Optimal HIV Treatment and Prevention, answering the questions on choosing between initial ART options, featuring Dr. Marta Boffito and Dr. Michelle Cespedes. Dr. Boffito is a consultant physician and clinical director in HIV, sexual and gender health, and dermatology at Chelsea and Westminster Hospital, NHS Foundation Trust, Imperial College London in London, UK. Dr. Cespedes is a professor of medicine in the Division of Infectious Diseases at Icahn School of Medicine at Mount Sinai in New York, New York. For the full online educational program, please visit the link in the show notes for this episode. Now let's get started and hear what Dr. Boffito and Dr. Cespedes have to say about initial ART.
Great. Thank you, Jessica. This is Marta Boffito, and I'm going to start by going through the guidelines and what they recommend for first-line antiretroviral therapy regimens for the majority of people living with HIV. And then I will pass the word to Michelle, who will continue with other important areas around initiation of antiretroviral therapy. So as you can see illustrated here, although the majority of guidelines indeed recommend to start 2 NRTIs and a high genetic barrier second generation and unboosted, of course, integrase inhibitor, there are also alternatives either around the concept of 2-drug regimens. In fact, you can see that dolutegravir and lamivudine is one of the recommended combinations of antiretroviral therapy for initiation, but also interestingly, the European guidelines also report older integrase inhibitor like raltegravir and the NNRTI doravirine, the last approved NNRTI doravirine, together with again 2 NRTI, specifically either 3TC or FTC and either TDF or TAF. So this is really what is happening today around the world mainly. However, there are some hot topics around initiation of antiretroviral therapy. And weight gain, I'm sure you're aware, is one of them. In fact, this slide shows the results of a meta-analysis that was published on clinical infectious diseases a couple of years ago. And this meta-analysis highlighted the amount of weight gained after starting antiretroviral therapy, looking at different classes. So you can see that integrase inhibitors led to an increase in weight gain that was higher than other third agents such as protease inhibitors and NNRTIs. And within the integrase inhibitor class, bictegravir and dolutegravir led to a weight gain that was higher than elvitegravir cobicistat. And when we look at NRTIs to combine with the integrase inhibitors, TAF was the NRTI that seemed to lead to a higher rate of weight gain compared to other drugs followed by abacavir, TDF, and AZT. Interestingly, when they looked at other factors that may be associated to weight gain when starting antiretroviral therapy, the same study looked at race and gender and identified Black females as the group of people living with HIV at a higher risk of gaining weight after starting therapy, followed by Black males. And this is in accordance with the data that have been produced from other areas of the world, such as the advanced study from Sub-Saharan Africa where again, Black women seem to be at a higher risk of gaining weight after starting antiretroviral therapy. Interestingly, there are also cohort studies that look at weight gain, and the RESPOND cohort looked at the risk factors for weight gain, and they highlighted the use of dolutegravir and raltegravir, so the use of integrase inhibitors, the use of TAF, and the low pre-antiretroviral therapy initiation BMI and Black race as risk factors associated with significant weight gain. So in this context, Michelle, would you like to add anything to the data that we're showing? Any comments on that?
So the things I usually, take into account is what I've seen in my own clinic, how often, especially as we use integrase inhibitors almost exclusively for initiation of therapy. And I'd say the vast majority of our patients, even those more treatment experienced, are on an integrase inhibitor-based regimen. How often do I see weight gain on the order? And if we go back, the kilograms were about, anywhere from 2 to 5 kilograms over 2 years. And that's a significant amount of weight. I jokingly say 2 pounds here, kilogram here or there is not that much of a difference, but anywhere from 8 to 10 pounds over 2 years is significant. And of the hundreds of people that we've started on these regimens, I don't see that often. So then I take into account, who are these trials done in, right? And I think the RESPOND data that actually looked at the compounding factor of the pre-treatment BMI, whether someone was underweight, or what we would consider underweight, a BMI under 18, they were more than twice as likely to have this weight gain. So is this really someone who's, well-nourished, gaining 10 pounds in 2 years versus someone who may have already been ill or feeling the effects of their HIV, and this weight gain was more of a return to health or a return to their baseline. I think the other things that we have to take into it is, age of the participant, hormonal differences between men and women, what's culturally accepted. I remember years ago noticing that some of my patients were asking for supplements or how they can keep their weight up. I'm like, but technically you're already overweight or your weight is fine, but culturally was more desirable. So wasn't necessarily thought of as an adverse event or something of the sort. So I take into account who the patient is, what their starting point was, and how often I see it. But again, I think, it is a concern of people. So I make sure we have that discussion and talk about the data as well. And similarly with the differences between tenofovir alafenamide versus the dioxyl fumarate, the older, I call it the 1.0 version of tenofovir. There does seem to be a correlation in more than one study with more weight gain with the tenofovir alafenamide preparation. But as we kind of look into more depth, is it maybe that over the years, the TDF formulation actually suppressed weight gain? So it's not that it necessarily TAF is so much worse, but that TDF actually might have some weight suppressive effects. There's some data in some switch studies, people who initially started on TDF and then switched to TAF, that might be the case. But I think more data is needed and more time in observing people over time. But especially as TDF falls out of favor here more in the States because of some patent issues and safety profile and data. But around the world, we actually might see that being useful.
Yes, indeed. That is very true. But very interesting, you did say about having the conversation and following and monitoring people. And this is really important, I think, because when we talk about weight gain, we're not just thinking about those extra kilos, but obviously we need to also look at the potential development for cardiovascular disease and metabolic syndrome. And
Absolutely.
data today are available showing that cardiovascular event risk is higher. We know that cardiovascular disease is higher in people living with HIV compared to people without HIV. Interestingly, however, there's extra factors that have been shown that seem to be associated with an increased cardiovascular event risk. So from the RESPOND cohort, integrase inhibitors have been shown to be associated with an increased rate of cardiovascular events for the first 24 months of INSTI exposure compared to no INSTI exposure. So this is a prospective cohort, but very, very important data that made us talk a lot about it. These data were published on Lancet HIV last year. A lot of conversation around this. Now, recently, however, at CROI, a data from the Swiss HIV cohort study were presented, and they looked at the impact of integrase inhibitors on cardiovascular events again, in Switzerland. So basically what they looked at people who started on integrase inhibitors or started on other antiretrovirals and calculated the cardiovascular event risk. And the baseline characteristics were not remarkably different. However, in the group that started integrase inhibitors, there was a higher percentage of people on abacavir. This was probably driven by the single tablet combination, including abacavir, lamivudine, and dolutegravir when it was introduced into clinical practice, and also a remarkably higher percentage of people on TAF. And this is again probably due to the availability of the big FTC TAF single tablet combination. So I think this is worth noticing. None of the other baseline characteristics were remarkably different. And interestingly, they showed that there was no difference observed in adjusted cardiovascular events incidence between integrase inhibitor-based heart compared to other antiretrovirals. And again, when the analysis was adjusted for the baseline characteristics, which is very interesting, quite new, again, if you think about the data published a year before that from the RESPOND cohort. I don't know whether you want to add any comments on this, Michelle, because I think it really shows that we need more data, right? Because we need an answer.
Absolutely. So the RESPOND data is a much larger cohort, but I think it is important that we adjust and take into account, modifiable factors and some non-modifiable, right? So this study actually took into account, race, gender, and some other factors. But I think it's important if you kind of are myopic about it, you can pick one drug or one class of drug that definitely seems to have a much larger incidence over time. But I like that this study has a longer observation time, so all the way out for 8 years, looking at some of this data, right? So even though it's a smaller cohort, the 8 year
it's very important for cardiovascular events, indeed.
Correct.
Absolutely.
Correct. And, as you pointed out, the importance of weight gain, the couple of pounds here or there, but oftentimes, when we take into account not just weight, but some of the other metabolic risk factors, you were talking metabolic syndrome factors, sometimes those extra pounds or the slight change in your blood pressure can switch you over into a category where now it would be, your ASCVD score. I'm not sure if Europeans use the same score, but when we calculate who should be on a statin or not, for protective purposes, sometimes the change in weight can actually flip you into another category or increase your risk of developing diabetes and things of the sort. So weight, as we think, modifiable risk factors, modify them, right? Better diet, more exercise. But sometimes it can actually put you into a category. And we know that HIV in and of itself might be a high enough risk factor. Hopefully we'll be getting more data from the Reprieve study. But there might be something just about HIV in and of itself that you're already in a higher category. And some of these calculators that we use to determine who should be on more protective medicines and prophylaxis might be moot for HIV.
Absolutely. And yes, you raised a really important matter, which is modifiable and lifestyle. I think it's the only factor that we are 100% sure it helps. Right?
Correct.
The data are immense.
That we can counsel patients on.
We can control the data within the HIV field, outside the HIV field are immense on the topic. We know that diet and exercise is the best you can do in whatever context.
And getting patients to stop smoking. I always tell that to the students as well.
Absolutely. And this is published within the HIV field where, it is these main factors that can really decrease, of course. Let's never forget about that. Great. I'm just going to let you lead towards the end.
So what we do are considerations for patients of childbearing potential. So here in the U.S., Department of Health and Human Services recommendations for people living with HIV who are of childbearing potential. What it clearly states is that contraception should not be required to actually start antiretroviral treatment regimen or continue them for an individual patient, even if there's limited data on pregnancy. So for the vast majority of all of the data that we have on the safety in pregnancy, we really get from reported outcomes in pregnancy from the Antiretroviral Pregnancy Registry. Ideally, providers, when they have a patient who is pregnant, either is diagnosed with HIV during the pregnancy or already known and becomes pregnant while on treatment, their data should be entered and actually followed longitudinally. Ideally, it's much better than actually reporting the data after the pregnancy. What we are concerned, or what we've seen in the past, is that if there is an adverse outcome, either with the mom or the child, then that data is, preferentially reported after the birth. And so that you actually might have a bit of a bias of reporting. We think that may have happened years ago with the Faverns. But ideally, all pregnant women or all women who are exposed to antiretrovirals should be included in the registry. The next point is actually states that healthcare providers should engage in what's called shared decision making, really providing our patients with information, counseling, talking about the risk and benefits, and having them be an active participant in the decision on which regimen to start or to continue. Lastly, whenever possible, really, our main goal is actually to prevent mother-to-child transmission. And data has shown really getting the mom undetectable, or at least a viral load under 1,000 by about week 36 or so, ideally. So, time is virus. You really just want to make sure you have enough time to get the patient undetectable before delivery. If that's not possible, we actually would advise a C-section. But again, a natural birth is better for both the mom and the baby, and whenever possible. So getting the patient undetectable is the. Of course, as drugs get easier to tolerate, and especially with the integrase inhibitors, where there are fewer drug-drug interactions, that we still have to be mindful of the potential of changes in either the concentrations of the antiretrovirals or sometimes of the contraception being used. This is a chart of the most common or probably the most significant drug-drug interactions between first-line antiretroviral regimens and contraception. The good news is that even though there are occasionally interactions that affect the PK or the blood concentrations of the contraception or the antiretroviral regimen, these changes, even though 27% sounds high, these changes are actually not considered significant enough to actually modify or change the dosing or dosing interval for the antiretroviral. So even with the potential of changes in concentrations in the blood, no dose adjustment is needed for the antiretrovirals that are listed as first line in pregnancy and for initiation of therapy and commonly used contraceptive. So I'm not sure, Marta, what are the most common modalities of contraception where you provide care?
Yeah, so I mean, the implant is very popular. Progesterone long-acting is popular, but also oral contraceptives, coils, a bit all of them. It's great to have a choice because, we're all different and we all have different lifestyles. So, yeah, I mean, it's fantastic to see this data and these recommendations where we don't have to worry about drug-drug interactions anymore. With the older antiretrovirals, you really felt that women were left behind from a contraception point of view.
Right.
And today, the fact that the antiretrovirals don't affect or very, very small changes, as you said, below 30%, so not clinically significant, but they don't affect antiretrovirals. So the contraception doesn't affect antiretrovirals, and especially antiretrovirals don't affect contraception is fantastic because we're really able to deliver equitable care to everybody and use effective and well-tolerated combinations.
I agree. I think as people become more confident, what I've seen over the past 2 decades is the increased use of IUDs, even here in the States. Some hormonal, some not, actually. Even having conversations with patients, I think I used to think that people would be reluctant to have, a foreign body there, but actually as data and safety has shown that it's safe and effective. And, most of the population is using it with confidence as well. Our patients are just being treated no differently. So just quickly, just wanted to go over first line what the guidelines say, just based on data. So remember, a lot of this is based on data and smaller either cohorts or safety and PK studies or first-line ART regimens to initiate during pregnancy. Being mindful that if a person of childbearing potential actually becomes pregnant on a regimen that might not be first-line in the guidelines, but they're doing well on and they're undetectable and tolerating well, what we can sometimes recommend is actually maybe more frequent monitoring more of the viral load, especially during the second and third trimester, as the volume of blood increases for all pregnant women. So the way I explain it to patients is to think of it as, even though you're putting the same amount in your body, we're diluting what the concentration might be. As your blood volume increases, we have to be more mindful of the effectiveness of the drug. Right? So again, similarly, a lot of data and the safety of dolutegravir in particular in terms of integrase inhibitor, but around the world and just without over decades of experience, we still have NRTIs as frontline as well. Protease inhibitors have fallen out of favor, I think more not because of effectiveness, but more tolerability and drug-drug interactions, and sometimes can be just more nauseating than some of the other regimens. So again, we always take into account tolerability and efficacy as well. In terms of the backbones, still recommending a 2 NRTI backbone for first line, again, just based on years and years of data. There's insufficient evidence or data to whether or not a 2-drug regimen alone would be sufficient in pregnancy. But I think as more people become pregnant on it and we have more data, if all the data is included in the registry, we will see more data over time. And you mentioned earlier just really how frequently the fixed dose combination of bictegravir, emtricitabine, and tenofovir alafenamide is used. Definitely here in the States. And in Europe, I believe more so than in other resource-limited settings. There are more and more women who are not, I shouldn't say more and more patients of childbearing potential who can become pregnant or become pregnant on that regimen. So we are seeing some data, not large data sets, but again, not sufficient enough to be lifted up or lauded in the guidelines as well. But I think over time, we'll get to see more data of the use of the fixed dose combination that includes bictegravir in pregnancy. Let's go over just a few of the take-home points of the slides that we presented so far, and then we'll open it up for a conversation both between Marta and I and the group and viewers as a whole. So our take-home points would be, in terms of weight gain for people living with HIV, there have been meta-analyses and data over time that has showed some of the consistent risk factors have been a Black race, low pre-treatment BMI, and for the RESPOND data, that BMI, I believe, was lower than 18, if I remember correctly, 18.5. And the combination of the use of integrase inhibitor and tenofovir alafenamide in particular for weight gain. In the RESPOND study, cardiovascular events really increased within the first 2 years of integrase inhibitor exposure compared to those who did not initiate treatment with an integrase inhibitor. But in contrast to that, for the Swiss HIV Cohort study participants, after adjusting for baseline characteristics, there was no difference in the rate of cardiovascular events over time over the 8-year study period. And lastly, I think it's important to state that it's important for all of our patients who have the ability to become pregnant, really discussing fertility desires. And what I mean by that is usually, do you intend to have any children or any more children if you already have children? What contraceptive are you currently using? Making sure they're aware that they can prevent the transmission from mother to child. I've had patients who actually didn't realize that once they became or were diagnosed with HIV, that they actually could have a child who was not HIV infected. So making sure you have a shared decision making and a discussion about fertility desires and contraception. And I've fallen victim to this too. I'm much better at it now. But making sure we actually do a pregnancy test before we initiate therapy, and actually when we switch therapy too. Sometimes it can be several weeks before someone is actually aware that they are pregnant, and it's always best to be mindful of that. I think we do all the other checklists with labs and viral load and resistance testing, and sometimes don't even simply have some of our patients urinate into a cup really quickly to make sure that we're doing everything as safe as possible. But being mindful of the conversation is actually helpful. Marta, do you take care of patients who become pregnant or continue to have children over time?
Yeah, indeed. We do have not very many, not high number, but we definitely see women living with HIV who are conceiving on antiretrovirals or are diagnosed during pregnancy and needs to start antiretrovirals. If you don't mind, I'm going to ask you a question about it, because so recent data show that switches of antiretrovirals in pregnancy don't seem to affect efficacy and viral load outcomes. However, other data show that the mental health and the confidence in antiretroviral therapy of the woman can be affected. So changing antiretrovirals during pregnancy can cause distress. What is your experience with the newer combinations? Do you still think that we need to try to be as consistent as possible and worry about it, or just go with the flow, the guidelines, and not worry too much?
I think the most important thing, again, is maintaining viral suppression. So keeping my patient undetectable, both for her health and safety and that of the baby. I think what I tend to do, actually, if someone is tolerating a regimen well, and even if it isn't, the highest or has the best data on the guidelines, what I've done is actually having the conversation with the patient. This is the data that we know. This is some of my experience, and making sure that she knows that she's an active member in the decision making. But I will tend to actually keep them on a regimen if I think it's not contraindicated, or when she hasn't been having trouble, or we don't see any viral blips. And we'll tend to actually viral load test them a little bit more frequently in the third trimester. I really just want to make sure, and reassuring her as well, that we can maintain viral suppression. So I think, there's data, and there's, what's the true principle? What we're trying to do. Our job is to keep them undetectable and prevent the baby from becoming positive. And we get that with viral suppression. So if someone is suppressed and on a regimen that isn't completely contraindicated in pregnancy, and those are few and far between at this point now, just based on some of the more modern regimens that we use, I will tend to keep someone on a regimen, namely because the fixed dose combination of bictegravir, emtricitabine, FTC, I'm making sure I'm not using any commercial names, is so common. Having that discussion and keeping them on it if they're in agreement with it, or switching them to something that's comparable and tolerable that will maintain that viral suppression. Now, if I have someone who is initiating therapy, recently diagnosed, but plans to become pregnant within a year and a half or so, I maybe would not put them on that regimen to start. I might put them on a pregnancy-friendly regimen based on the guidelines to start with, and then carry on from there. Then I'm less likely to switch if things are going well.
So if someone is on dolutegravir and lamivudine and refuses to switch, what would you do? Sorry to put you on the spot. I'll tell you what.
No. It hasn't come up for me as yet. But again, I think the data is limited, but I think I would be confident enough again to continue the frequent viral load monitoring. And especially after I've had the conversation and they say that they do not want to switch. I think in all honesty, I personally might be more comfortable on a 3-drug regimen. But after having the conversation and the patient tells me that they do not want to switch, after we've discussed the risks and, what we're concerned about, doing the frequent monitoring.
I agree with you. I mean, there's a lot of data on dolutegravir, efficacy in leading to an undetectable viral load when starting pregnancy, and also maintaining an undetectable viral load. And you said it a few times, and I think it is the most important thing, making sure you have the conversation, you share the data, and you make the person in front of you be part of the decision. So they, in the ideal world, you would start the F at least for the third trimester just because that's what we know. But if you can do the monitoring and the viral load remains undetectable, maybe we should start accumulating data, report the pregnancy on the registry, because that's really important. It is when we have enough pregnancies on a certain combination, right? On the registry, that we can then be confident of that. So, yeah.
And with components that I'm confident in, that I've used for years. I remember your original slide when we talked about the different guidelines for not in pregnancy, but for all comers. The European AIDS Clinical Society guidelines actually include doravirine, which I don't use commonly, right? So maybe if someone was pregnant in a doravirine-based regimen, I'd be a little bit more skittish because I'm not too familiar with it. Hasn't been around that long. Definitely much less data in pregnancy. Do you use doravirine commonly or often?
We use doravirine a lot. We don't think, we do actually. Yeah. That's why it's in Europe, that's why it's on the EACS guidelines for starting. It's a well-tolerated drug, and however, we don't have data on the third trimester in terms of exposure. So we are cautious and we follow guidelines. Yeah.
I definitely think patients pick up on our nervousness too, right?
Yeah.
I'll say this is a drug I don't use often and it should work, but I'm not familiar. I think, we definitely have more influence over our patients, even with shared decision making. But it is important to do.
Yeah. So there's a question that says, "Can you speak about breastfeeding, please?" Do you want to tell us your
recently here in the States? I'm not sure in Europe, but recently here in the States, actually, what we were noticing is, essentially the principles are the same, right? In terms of mother to child transmission, the vast majority happens at the time of delivery, but of course earlier in pregnancy. But there is a fraction that actually happens postpartum. And it can be sometimes associated either with the immaturity of the GI tract of children, but it's actually thought maybe more commonly with maybe micro tears or mastitis or maybe some virus getting into breast milk and breastfeeding. So for many years, especially in the resource-rich settings, we said, don't even risk it. Formula feeding is best. Why risk exposing the child? But I think that sense actually doesn't take into account that access to formula feeding and even just clean water in many places of the world is disproportionately affected by HIV. Your child is more likely to die of a diarrheal illness if you don't have access to clean water. And breastfeeding can be healthier if you can, right? So ideally with breastfeeding, we do want the prophylaxis for the baby for at least those 6 weeks. We want the mom, of course, to be undetectable if possible. But now, again, we are actually advocating for more of a shared decision-making in terms of counseling the mothers with breastfeeding. And what we really want to do is take away the stigma and sometimes even the criminality of some of the cases that we've heard around the country where people can either be threatened or actually have their children taken away if they decide that breastfeeding is the option that they want to pursue. So in terms of breastfeeding, again, we want undetectable as much as possible, safest options, making sure that there's shared decision-making and people know the risk, that there is a slight risk, even if a mom is undetectable of transmitting to the child, but that they are not, either going to be risk any criminal threats or risk of losing their child. I'm not sure what the sentiment is in Europe. That'd be
similar, very similar. We're moving really much towards that. Yeah, very similar. So burning question, because I think you already said it. Would you switch someone who is already suppressed on BHIVA to a dolutegravir-containing regimen if they are contemplating pregnancy?
If contemplating pregnancy, probably not. Probably not. I would discuss with them the data. I think if someone has not started a regimen yet and they're just initiating and they're saying that they plan to become pregnant in the next year or two, that might be different. But if someone is already tolerating it and doing well and saying that I probably want to become pregnant in the next year or two, I think the risk of someone getting off schedule or risk of maybe not tolerating a new regimen as well is probably higher than the risk of them actually transmitting to their unborn child during the pregnancy or after. So I would actually probably, in my opinion, continue them on their current regimen that they're tolerating well, do the counseling, and make sure that I check their pregnancy tests every time they come to see me.
Great. Okay, now we're going to move away from pregnancy. And
No!
we'll get back.
Okay.
We'll get back there. This is very interesting. I'm going to share my experience if it's okay. And then please do add what you think. So if someone is failing oral PrEP with TDF-FTC, I would imagine, and this is what we have approved here in the UK, for example, and in the majority of European countries, and TAF is actually TAF-FTC around the corner in the context of PrEP. But if someone is failing oral PrEP, would you do a rapid start with a boosted darunavir or dolutegravir or wait for genotype? So our experience is that the likelihood for them to actually have an undetectable viral load and a very slow seroconversion is quite high. So usually we add dolutegravir. Keep in mind, again, we have TDF-FTC, so we would just add dolutegravir, do all the determinations that we need to do, make sure, that the diagnosis is confirmed, and sometimes even send off a proviral DNA, because that is the only test that we can request, because we don't have enough viral replication to actually run a resistant test on the RNA. And we have experience, we see here in one of our clinics in Dean Street, an incredibly high number of people on PrEP and some seroconversion inevitably. So that's what we do. We don't tend to use the boosted PI as much anymore. We do use the high genetic barriers, second generation integrase inhibitor. And it's the Levy or Levi syndrome has been described for cabotegravir, but that is very similar to what we are seeing in the context of seroconversions on PrEP. I don't know whether you have anything else that you want to add from your experience.
I agree. I think of the integrase inhibitor, the addition of the integrase inhibitor as the gold standard. And there is data even for people who are on for a second line switch, even if there is a distant history, an M184, even putting them on dolutegravir 3-TC alone, where you think might not be safe or might not be ideal, when they actually go and look through resistance testing, or these people can actually suppress even on second line therapy. So it makes sense that if it's first line, and I'm not sure if I truly believe that it's true resistance to those TDF, FTC, or when the breakthroughs from PrEP, or when someone does seroconvert. But I think an integrase-based regimen would often be fine. And now we get information in 2 weeks, 3 weeks. We wouldn't be doing harm or really fostering the creation of a highly resistant virus by the time we get more additional information. So I agree with your approaches.
Yeah, great. We also have a question on weight gain. So basically, they're asking us in people on integrase inhibitor whether there is a different proportion of weight gain in people on TAF versus TDF, which I think it's quite clear from the advanced study that people with the integrase inhibitor and TAF gain more weight, especially women, than with TDF. And then if we look at, and this is in people who started treatment, and then if we look at later on when they switched to TDF, when everybody switched to TDF, the people on TAF had a decrease in weight, which is exactly what you said earlier, where TDF seems to have a weight limiting effect. I think the role of the booster in weight gain, there is a role of the booster in weight gain that may confuse the picture a little bit. I don't think we can say TAF causes weight gain. I don't think we know. We know that TDF limits the weight gain.
Wondering almost like, should I consider TDF and, take advantage of it for its weight suppressive effects? But then, there's either the data and what about renal, and what about bone density, and taking all these other things into account. So it's not easy, but since I don't really use any boosted, I get rid of boosting anytime I can. I think that in the long run causes more harm than good.
Absolutely. We are trying to move away, aren't we? To move away from boosters anyway, because I think we contribute to improve the quality of life of people living with HIV.
Correct.
They are not on boosted agents because there are less risk of drug interactions and negative outcomes.
Correct. And sometimes I think people forget that, they might not be on a drug that they'd have a drug interaction now, but maybe 5 years from now, statins are safer now, but maybe everyone will be on a statin. I briefly mentioned the Reproof study, or, biologics and things of the sort. I think we have to keep in mind that even if they're not on this medicine now or don't have this diagnosis now, as biologics become more commonly used for, cancer and other autoimmune diseases, we have to think about the future, or, anticipating that our patients will live 10, 20 more years. And oftentimes I think that especially specialists can get into silos. I only think about my medication or the medication I put them on, and not really the whole compendium.
Absolutely.
Thank you very much to Dr. Boffito and Dr. Cespedes, and thank you to our listeners for joining in. Please be sure to check back regularly for more episodes on important infectious disease topics. Thank you and have a great day.